Hello, I am Ann DeMaio. It is a pleasure to speak to you today about pulmonary. Let's begin with the objectives. List the indications for using oxygen. Describe 3 general presentation symptoms of a respiratory condition. List the diagnostic tests to be ordered for an infant with a respiratory condition. Explain the nursing care for an infant with a pulmonary condition. Identify the nursing considerations for the administration of common respiratory medications. We're going to start with embryology. In the first 5 weeks of fetal development, the lung develops from a single bud into lobes. The pulmonary vein also begins to develop. During weeks 5 to 17 of gestation, the conducting airways form, including cartilage, main bronchus, terminal bronchioles, diaphragm, and capillary bed. Failure of the diaphragm to close during development at this time can cause congenital diaphragmatic hernia, that is, the abdominal contents herniate into the thoracic cavity through a hole in the diaphragm. Between 17 and 24 weeks gestation, gas-exchanging units appear. The airway increases in length and diameter, and the vascular system proliferates and the bronchioles differentiate. At 28 weeks gestation, there is accelerated growth in lung volume and an increase in type 2 alveolar cells, which secrete surfactant. However, if the birth occurs before or at this time, type 2 alveolar cells do not secrete enough surfactant to keep the alveoli open. So the infant is at risk for respiratory distress syndrome, also known as RDS, as well as pneumonia and bronchopulmonary dysplasia, which is termed BPD, and which is diagnosed later. After birth, or at 37 weeks gestation, the alveoli continue to mature and the lungs continue to increase in size for 8 to 10 years. Conditions that usually occur in the term or near-term infant include spontaneous or iatrogenic air leaks, transient tachypnea of the newborn, or retained lung fluid syndrome, meconium aspiration syndrome, as well as a possibility of persistent pulmonary hypertension of the newborn. Fetal stress can accelerate lung development. Some conditions known to accelerate surfactant production include maternal hypertension, narcotic or methadone use, premature rupture of membranes, placental insufficiency, maternal corticosteroids, and chorioamnionitis. Conditions that delay surfactant production include hydrops fetalis, maternal diabetes, oligohydramnios, pulmonary lesions, fetal insulin, acidosis, hypoxia, hypercarbia, and shock. Lecithin to sphingomyelins, which is the LS ratio, is used to evaluate fetal lung maturity. A ratio greater than 2 to 1 indicates that fetal lung surfactant is in amniotic fluid. The surfactant usually appears at around 35 weeks gestation. Phosphatidylglycerol is present in amniotic fluid at around 35 to 37 weeks gestation. It is reported as positive or negative and is a more accurate measure for mothers who have diabetes. Fetal lung maturity assay measures surfactant albumin ratio, and greater than 55 milligrams per gram indicates mature lungs. Physiology. Oxygenation is oxygen into the body. Breathing is controlled by neurologics, central nervous system maturity, sleep state, and reflexes, and chemical, which are oxygen and carbon dioxide levels, chemical reflexes. Fraction of inspired oxygen, which is termed FiO2, can be room air, which is 21%, or supplemental, which would be considered 22 to 100%. Ventilation depends on ventilation perfusion ratio and lung compliance. VQ ratio is the relationship between pulmonary perfusion, blood flow to the alveoli, and pulmonary ventilation, aerated alveoli. A decrease in the VQ ratio indicates decreased ventilation compared to perfusion, as found in atelectasis, respiratory distress syndrome, pneumothorax, and pneumonia from aspiration. An increase in the VQ ratio indicates decreased perfusion compared to ventilation, as in pulmonary emboli, pulmonary stenosis, and tricuspid atresia. Lung compliance depends on the amount of surfactant and the elasticity of the lung tissue. Surfactant reduces surface tension and keeps the alveoli open and free of lung fluid. It helps improve lung compliance and is important for pulmonary capillary perfusion. The elasticity of the lung tissue describes the change in lung volume that occurs with a change in pressure. Perfusion depends on oxygen delivery. Oxygen delivery is the amount of oxygen delivered to the tissues. It depends on cardiac output and the oxygen content of the blood. The respiratory system is responsible for supplying oxygen to the body through gas exchange. Inhaled oxygen travels to the lungs and alveoli. Oxygen passes through alveolar cells and into capillaries very quickly. Carbon dioxide from the blood goes into the alveoli and is exhaled. The superior and inferior vena cava carry the oxygen-depleted blood, which is rich in carbon dioxide, to the right atrium. Blood flows from the right atrium to the right ventricle and into the pulmonary artery to the lungs, where the blood picks up oxygen and releases carbon dioxide. Pulmonary veins carry oxygenated blood to the left side of the heart for circulation. The left ventricle of the heart pumps oxygenated blood to tissues. When we observe the respiratory pattern, the effort to breathe is unlabored, with a respiratory rate between 40 and 60 breaths per minute. Periodic breathing is characterized by breathing pauses less than 20 seconds, not associated with color change during sleep. Variations from the normal include tachypnea, which is a respiratory rate greater than 60, and it indicates respiratory distress, possibly, or congestive heart failure, sepsis, hypothermia or hyperthermia, hypoglycemia or polycythemia. Apnea, another variation from the normal, is no breath for longer than 20 seconds with bradycardia and color change, and indicates hypothermia possibly, or hyperthermia, sepsis, prematurity, respiratory, cardiovascular, or neurological disorders. Also, maternal narcotics or hypoglycemia may contribute to apnea. Retractions, grunting, flaring, and seesaw respirations are associated with respiratory distress, and asymmetrical chest movement may be due to pneumothorax or lung lesion. Auscultate breath sounds in a consistent pattern to assess all lobes. Variations from the normal include rales, also known as crackling, which may indicate respiratory distress with fluid in the lungs, rhonchi, sounding like snoring, which may indicate respiratory distress when there is a large airway obstruction, rubs or grating, which may indicate respiratory distress associated with pleural fluid or inflammation, stridor, which is a hoarseness, which may indicate respiratory distress from partial upper airway obstruction, wheezes, squeaking, which may indicate respiratory distress. When we examine the chest is normally round and symmetrical and usually measures slightly less than head circumference. Variation from the normal includes barrel chest, which may indicate a hyperinflation or meconium aspiration. Tidal volume is the amount of air in and out of the lungs with each single breath at rest. Lung capacity includes vital capacity, the amount of inhaled and exhaled air; functional residual capacity, the amount of gas remaining in the lung after exhalation; total lung capacity, the maximum amount of air in the lung with inspiration. Dead space includes physiological dead space, the anatomic dead space, or the volume of air of an area where gas exchange does not occur, plus alveolar dead space, which is the amount of gas reaching the alveoli but not being exchanged because of poor perfusion. Dead space also includes mechanical dead space, which is the gas in the ventilator circuit plus exhaled gas. Minimal amount is preferred. The oxyhemoglobin dissociation curve describes how oxygen interacts with hemoglobin. The curve is based on a comparison of partial pressure of arterial oxygen, also termed PaO2, and oxygen saturation. As PaO2 drops, so does oxygen saturation. The relationship is not linear, so the curve is more S-shaped. Oxygen saturations, the percentage of the hemoglobin saturated with oxygen, also known as SaO2, will stay at and above 90% until the PaO2 drops to approximately 60 millimeters of mercury. Below this range, the curve drops drastically. Variations in pH, carbon dioxide, 2,3-diphosphoglycerate, also known as 2,3-DPG, and temperature can cause the curve to shift to the right or left. A shift to the right indicates that a higher PaO2 is needed to maintain high oxygen saturation. A shift to the left indicates high saturations, even with normally low oxygen levels. This is why drowning victims can be saved with little or no brain damage even after long submersion. Hypothermia and acidosis shift the curve to the left to maintain high oxygen levels in the blood. Hypothermia also lowers metabolic rates, so the body uses less oxygen. Factors affecting the curve would be a decrease in pH shifts the curve to the right, and an increase in pH shifts the curve to the left. Carbon dioxide affects the curve by influencing pH and by generating carb amino compounds from PaCO2 accumulation. Low levels of carb amino compounds cause a right shift, and higher levels cause a left shift. 2,3-DPG is created in red blood cells during glycolysis. High levels of 2,3-DPG shift the curve to the right, and low levels cause a left shift, as in septic shock and hypophosphatemia. Hyperthermia causes a right shift, and hypothermia causes a left shift. Carbon monoxide interferes with hemoglobin binding to oxygen. Carbon monoxide shifts the curve to the left. An increased level of carbon monoxide may cause severe hypoxemia with a normal PaO2. Methemoglobinemia causes a left shift in the curve. Fetal hemoglobin is structurally different from adult hemoglobin. The fetal dissociation curve shifts to the left relative to the curve for the normal adult. Fetal arterial oxygen pressures are low, so the left shift enhances placental uptake of oxygen. Terms related to low oxygen. Hypoxia, a low level of oxygen in the tissues. Some of the causes of hypoxia include anemia, heart failure, abnormal hemoglobin, and shock. Hypoxemia, low oxygen level in the blood, PaO2 less than 80 millimeters of mercury. Threshold may be different for preterm infants. Arterial blood oxygen level is low due to intrapulmonary shunt from ventilation perfusion mismatch, as seen in atelectasis, hyaline membrane disease, pneumonia, and hypoventilation. Extrapulmonary shunt from blood bypassing the lungs for oxygenation, as in congenital heart disease and pulmonary artery hypertension. Asphyxia is a lack of oxygen or excess carbon dioxide in the blood, usually caused by breathing interruption. Cyanosis describes blue appearance of mucous membranes, most reliable site for assessing cyanosis. may be difficult to assess in infants with anemia due to decreased circulating hemoglobin, and is not visible until the oxygen saturation is 75 to 80%. Hypercapnia or hypercarbia, high carbon dioxide, PaCO2 content of blood, PaCO2 greater than 45 millimeters of mercury, may indicate airway obstruction. Low carbon dioxide levels cause cerebral vasodilation, increasing cerebral blood flow, and intracranial pressure, which is undesirable for preterm infants. Pathophysiology. The first sign of a respiratory condition is often labored breathing and low oxygen. To see the etiology of labored breathing and low oxygen, follow the physiology of airflow. Inhaled oxygen enters the lungs and the alveoli. Breathing interruption due to an obstruction, such as fluid, blood, or meconium, causes labored breathing and low oxygen level. Oxygen passes through alveolar cells into capillaries. Interruption of oxygen flow due to surfactant deficiency, atelectasis, vasoconstriction, pulmonary hypertension, alveolar overdistension causes an air leak, or anatomic abnormality causes labored breathing and low oxygen. Carbon dioxide from the blood passes into alveoli for exhalation. A breathing interruption from an altered respiratory rate, such as from a central nervous system depression, metabolic disturbances, causes labored breathing. Pulmonary veins carry oxygenated blood to the heart for circulation. There is interruption of breathing from a cardiac abnormality or hematologic disorders, such as anemia, causes labored breathing and low oxygen. Labored breathing, the pathophysiology. There is hypoxia from an obstruction, fluid or meconium, surfactant deficiency, vasoconstriction, alveolar overdistension, anatomic abnormality, or an altered respiratory rate causes. Shallow or increased work of breathing, also known as tachypnea, and decreased breath sounds. We manage this by performing a physical assessment, reviewing history, considering medications, and notifying the physician or a practitioner of the change. And also we manage this by delaying nipple feeding to prevent risk of aspiration if the respiratory rate is greater than 60 breaths per minute. Also in the pathophysiology of labored breathing, an attempt is made to keep the lungs open. This is done by grunting or nasal flaring. Because an infant's chest wall is very flexible, diaphragmatic contraction with distress causes sternal and intercostal retractions. We manage by continuing positive airway pressure. We manage this by providing continuous positive airway pressure, which is also known as CPAP. Pathophysiology of decreased gas exchange causes low oxygen desaturation. We manage this by providing oxygen to maintain appropriate saturations for gestational age or as ordered, increasing oxygen delivery to the tissues by decreasing oxygen demand, decreasing oxygen demand by maintaining temperature, limiting stress to conserve calorie expenditure, and treating pain. Retraction sites. Intercostal is between the ribs. Subcostal is just below the subcostal margin. Suprasternal is above the sternum. Substernal is below the sternum. Work of breathing, abnormal findings, increased effort, and shallow breathing. Rate, abnormal findings, tachypnea and apnea. Chest shape, abnormal findings, barrel chest and asymmetric chest. Breath sound symmetry, abnormal findings, absent or decreased sounds, asymmetry in lobes. Breath sound clarity, abnormal findings, rhonchi, wheezes, crackles. Color, abnormal findings, pale color, cyanosis. Temperature, abnormal finding, cool extremities. Capillary refill, abnormal finding, greater than 3 seconds. Pulse oximetry, abnormal findings, oxygen saturation less than 90% on room air, baseline change. Arterial blood gas, abnormal finding, acidosis or alkalosis on arterial blood gas. Crying. Cardiac etiologies will have increased cyanosis. Pulmonary etiologies will have decreased cyanosis. Respiratory pattern. Cardiac etiologies may have tachypnea or slow, deep respirations. Pulmonary etiologies may have retractions, grunting, and tachypnea. Carbon dioxide level. Cardiac etiologies may have normal or decreased level. Pulmonary etiologies may have increased level. Supplemental oxygen. Cardiac etiologies may have minimal response. Pulmonary etiologies are usually responsive. Cardiac exam. Cardiac etiologies may have murmur and weak pulses. Pulmonary etiologies usually have normal exam. Electrocardiograph. ECG. ECG findings may be abnormal with cardiac etiologies, and ECG findings are normal with pulmonary etiologies. Echocardiogram. Echo findings may be abnormal for cardiac etiologies. Echo findings are normal for pulmonary etiologies. Chest X-ray. Chest X-ray will show abnormal shape and size and position of heart with cardiac etiologies. Chest X-ray may show lung disease with pulmonary etiologies. Oxygen and ventilation. Using oxygen. Oxygen is used to increase oxygen delivery to the tissues. Oxygen should be administered when saturation drops for respiratory distress or for cyanosis unless there is a known ductal-dependent lesion. Oxygen is used to prevent pulmonary vascular reactivity, persistent pulmonary hypertension of the newborn, also known as PPHN. Use oxygen for interpulmonary shunting. Optimal oxygen saturation SpO2 levels are based on the infant's gestational age and condition. Decreasing oxygen demands. Maintain a neutral thermal environment. Limit stress by recognizing and treating pain and conserving energy with decreased activities and stimulation. Avoiding oxygen toxicity. Oxygen toxicity causes alveolar damage, increased capillary leak, edema, inflammation, and eventually fibrosis, and may contribute to retinopathy of prematurity, ROP, for preterm infants. Titrate oxygen as tolerated. Set audible monitor alarm limits above and below parameters per unit protocol. Individualize alarm limits for each infant and adjust if the oxygen requirement changes. Research is inconclusive about normal oxygen saturations. Follow your unit protocol. General guidelines are as follows. For infants weighing less than 1,500 grams, maintain SpO2 levels between 88 and 92%. For term infants, maintain SpO2 levels between 90 and 95%. For acutely ill infants, maintain saturation between 87 and 95%. Wean oxygen when SpO2 levels are consistently above 95% every 30 minutes. For chronically ill infants, maintain saturation between 90 and 95%. Wean oxygen when SpO2 levels are consistently above 95% and the infant is stable every 12 to 24 hours. For an infant receiving oxygen or ventilation, continuously monitor breath sounds for change in equality and pitch, respiratory rate and work of breathing by monitoring the infant's chest vibration on high-frequency ventilation and ventilator settings, monitor for trends and changes to oxygen requirements, Oxygen saturation for decreases. Slight decreases in oxygen saturation may be the first sign of pulmonary hypertension in high-risk infants. Pulse oximetry reading, the saturation of hemoglobin bound to oxygen, adequate hemoglobin, and a good perfusion are needed for accurate reading. Skin color and perfusion. For change in color, gray, mottling, or cyanotic, perfusion may indicate a need for more oxygen. Skin for breakdown from pulse oximetry at site. Invasive monitoring equipment, arterial lines for leakage and drainage, circulation of the extremity distal to the arterial line. Non-invasive monitoring equipment, transcutaneous monitoring for burns or skin breakdown from adhesives for low birth weight infants. Calibrate these frequently. Pulse oximetry alarm limits for oxygen saturation and adjust when condition changes. Respiratory equipment, ventilator alarms to ensure they are on and audible with preset pressure relief valves to avoid excessive peak, inspiratory pressure, which is known as PIP, or positive end expiratory pressure, also known as PEEP. Ventilator, a licensed respiratory therapist should inspect ventilator frequently and change tubing per protocol. Oxygen concentration, record and analyze routinely. And emergency equipment, ensure that the bag, mask, and suction and an extra endotracheal tube is present at the bedside. Blow-by oxygen is intended for short-term use, such as delivery room or weighing, to deliver free-flow oxygen from a flow-inflating bag or oxygen tubing to an infant who has spontaneous respirations. The amount delivered depends on oxygen concentration, flow rate, distance from infant, and respiratory rate. A hood or tent is indicated for respiratory distress, hypoxia, and cyanosis. A hood over the infant's head delivers warm, humidified oxygen at measured concentrations. Ensure that the analyzer is calibrated inside the tent. Use a blender system for oxygen and use an appropriately sized hood. Monitor for heat loss by using warm, humidified oxygen. A nasal cannula is indicated for short or long-term oxygen use and allows increased mobility for feeding and development. Oxygen is delivered with a set flow rate. Flow rate can be conventional or high-flow blended oxygen. Continuous positive airway pressure, also known as CPAP, is indicated for atelectasis, apnea, respiratory distress, and pulmonary edema. CPAP delivers positive pressure, generally between 2 to 8 centimeters of water, by mask, nasal prong, nasopharyngeal prong, or endotracheal tube. Observe for abdominal distension due to excessive air entering into the stomach from the CPAP device. Consider aspirating the stomach every few hours to relieve distension or leave a nasogastric tube in place to vent the stomach. Monitor for occlusion from secretions. Remove prongs and clear secretions every 4 to 6 hours as needed. Monitor the nasal septum area in infants with a continuous positive airway pressure, nasal cannula, or nasal intubation. Humidity in the CPAP system should be between 80 and 90% to prevent drying of nares. Inspect the tissue on the septum for redness. Mechanical ventilation is indicated for respiratory failure, such as hypoxemia, hypercapnia, or acidemia. Surfactant administration, pulmonary insufficiency, severe apnea and bradycardia, central nervous system conditions, and surgery. Provides breathing support using mechanical ventilation, and intubation can be either oral or nasal. High-frequency ventilation is indicated for severe air leaks, pneumothorax, pulmonary interstitial emphysema, lung disease unresponsive to conventional ventilation, carbon dioxide elimination problems, pulmonary hypoplasia, diaphragmatic hernia, or persistent pulmonary hypertension of the newborn. Oxygen can be administered using any of several high-frequency ventilators. High-frequency ventilators use small tidal volumes with rapid ventilator rates in order to ventilate infants with severe respiratory failure. Types of positive pressure ventilation. The type of ventilator used is based on each infant's condition and disease process, previous ventilator support, and staff experience with the comfort of the ventilator. Oxygen and positive pressure can be delivered with a bag and mask or manual ventilation or with a mechanical ventilator. The bag should be equipped with a pressure valve release to prevent excessive pressure and can be used with a manometer. Positive pressure ventilation is useful during resuscitation and for short-term or emergency use. The most common type of positive pressure ventilator is used in the NICU is a synchronous, time-cycled, volume or pressure-limited continuous flow device. The PIP, inspiratory time, flow rate, rate of intermittent mandatory ventilation, and inspired oxygen can be adjusted. Other types of positive pressure ventilators include pressure-cycled, volume-cycled, or pressure support ventilators. Modes of patient-triggered ventilation. Two ventilator modes used in the NICU include intermittent mandatory ventilation and patient-triggered ventilation. The following are three types of the most common mode patient-triggered ventilation. Synchronized intermittent mandatory ventilation, also known as SIMV. It is a preset number of breaths synchronized with the onset of spontaneous breaths. The ventilator supports the infant's spontaneous breath with a preset PIP and inspiratory time. Unassisted breaths occur between ventilator breaths. Assist control mode, also known as AC, is that a synchronized breath is delivered with each spontaneous breath. If the patient does not have enough regular respirations, as with apnea, mechanical breaths are delivered at a set rate. Volume-targeted ventilation. Volume-targeted ventilation can be used in conjunction with either mode listed above, and the volume is set based on the infant's weight and disease. Modes of high-frequency ventilation. There are types of ventilators which use small tidal volumes with rapid ventilator rates to ventilate infants with severe respiratory failure, including high-frequency flow interrupter ventilators with both high-frequency and conventional options, high-frequency jet ventilation ventilators which deliver short, rapid pulses around 400 to 500 breaths per minute and are more effective for PCO2 elimination than oxygenation, high-frequency oscillator ventilation, which is used for higher mean airway pressure with less barotrauma and have active exhalation to remove carbon dioxide more efficiently. Concepts related to mechanical ventilation. Gas trapping occurs when there is more air entering the lung than leaving. This may be due to endotracheal tube obstruction or from meconium. Inadvertent PEEP occurs from gas trapping. Permissive hypercapnia is a strategy to avoid barotrauma by using minimal ventilator settings or avoiding mechanical ventilation. Carbon dioxide levels are allowed to remain high as long as the pH does not fall below 7.25. Rate of intermittent mandatory ventilation. The ventilator rate affects the ability to blow off carbon dioxide. The rate is adjusted to maintain an arterial carbon dioxide PaCO2 within the desired range for the infant's condition. Peak inspiratory pressure. PIP is the primary factor that determines tidal volume and affects the partial pressure of arterial oxygen. The ideal is the lowest PIP that will provide adequate ventilation. Increased PIP will decrease the carbon dioxide level and will increase partial pressure of arterial oxygen. Positive end expiratory pressure. PEEP is important for stabilizing atelectic areas for a gas exchange, improving lung compliance, and improving ventilation perfusion mismatching. an increase in people, increase carbon dioxide levels, and increase partial pressure of arterial oxygen. Fraction of inspired oxygen. Inspired oxygen should be adjusted according to the infant's condition. An increase in inspired oxygen will increase partial pressure of arterial oxygen. Mean airway pressure, which is the MAP, is the average pressure through the airway during inspiration and expiration. MAP depends on the ventilator rate, gas flow, PIP, PEEP, and inspiratory time. It's a measured but not set parameter that is ventilator dependent. Increasing MAP can reduce atelectasis and interpulmonary shunting. Airway. Monitor the endotracheal or nasotracheal tube patency and position. Secure the tube with a taping method that works best for the infant and for the staff. Monitor the tube for slippage or loosening and resecure the tube to prevent accidental extubation. Stabilize the tube during position changes. Keep an extra tube at the bedside. Confirm tube placement after intubation and x-ray and note the depth of the tube at the bedside. Use consistent position, such as head midline, for chest x-ray when confirming placement. Breathing. Monitor breathing pattern and equality of breath sounds. Condensation indicates that the endotracheal tube is in the lungs. Signs of extubation include audible crying, sudden deterioration, abdominal distension, agitation, cyanosis, bradycardia, decreased breath sounds, or chest wall movement. If extubation is suspected, troubleshoot the airway and call for help at any time. If not resolving, provide manual ventilation as necessary with oxygen and consider other causes such as air leak or tube dislodgement into the right mainstem. Suction is needed for audible or visible secretions. Changes in vital signs, agitation, or changes in oxygenation or ventilation. The amount of secretions is related to the condition. Use an appropriately sized catheter. Advance the catheter gently and not past the distance of the endotracheal tube. Monitor chest vibrations with high-frequency ventilation, which indicate lung compliance, airway patency, and effectiveness of ventilator settings. Monitor heart rate from pulse oximetry or an arterial line because chest vibration interferes with monitoring heart and respiratory rates. Circulation. Monitor oxygen saturation and arterial blood gas to minimize or avoid hypoxemia. Increase or titrate oxygen as indicated by clinical status and arterial blood gas. Change head position to avoid molding pressure points and to promote equal ventilation. Minimize stimulation to prevent agitation. Chest X-ray. Assesses the heart and silhouette. Assesses chest symmetry or asymmetry, aeration, and vascular markings of the lungs. Provides anterior-posterior, cross-table lateral, and lateral decubitus views. Position the infant on a flat surface with a head midline, shoulders level, not rotated, for an anterior-posterior view. Cover the infant's gonads and wear a lead apron. For blood gas interpretation, oxygen saturation levels are cited as 97 to 100%. For application in the clinical setting, a more ideal oxygen saturation range for term infants is 90 to 95%. For low birth weight infants, a range of 88 to 92% is ideal. Determining cause of acid-base imbalances. Determine if the pH is high or low, alkalosis or acidosis. Low pH indicates some type of acidosis. Next, look at PCO2 and bicarb. High PCO2 indicates respiratory acidosis. Low bicarb indicates metabolic acidosis. High pH indicates some type of alkalosis. Low PCO2 indicates respiratory alkalosis. High bicarb indicates metabolic alkalosis. Anytime the PCO2 and bicarb are both high or both low, it is a compensated process. Transient tachypnea of the newborn. The pathophysiology: an excessive amount or delay in removing lung fluid after birth causes tachypnea, grunting, retractions, and mild cyanosis, milder symptoms than other forms of respiratory distress, oxygen requirement of 30 to 40%, usually lasting 1 to 5 days, appears most often in term or near-term infants. We manage this by monitoring for evidence of PPHN or shunting. The infant may have better oxygenation in prone position, creating a low stimulus environment. Monitoring the temp, intake and output, and blood glucose. Delaying oral feeding if respiratory rate is greater than 60 breaths per minute. And administering a broad spectrum of antibiotics as indicated by the history. Identifying precipitating factors associated with retained lung fluid, including cesarean section without labor, breech delivery, second twin, maternal sedation, precipitous delivery, delayed cord clamping, and macrosomia. Transient tachypnea of the newborn. Note the diffuse haziness and streakiness on the chest X-ray. Respiratory distress syndrome, also known as RDS. In the pathophysiology, insufficient amounts of surfactant, lung hypoperfusion, or anatomic immaturity lead to atelectasis, edema, and cell injury, which causes increasing oxygen requirement with cyanosis starting at or within 3 to 6 hours of birth, deterioration if untreated, tachypnea, expiratory grunt, nasal flaring, and substernal or intercostal retractions, diminished breath sounds and rales with progression, hypoxemia, acidosis, and tachycardia, oliguria, and hypotension. We manage this by administering oxygen and ventilation as necessary, assisting with surfactant administration, monitoring arterial blood gases and electrolytes, monitoring blood pressure for hypotension, monitoring for complications including air leaks, persistent ductus arteriosus or PDA, chronic lung disease, intraventricular hemorrhage, and possible retinopathy of prematurity. Identifying precipitating factors associated with respiratory distress, including prematurity, cesarean section delivery without labor, and maternal diabetes, especially if the infant is born before 38 weeks, is a second twin, or has asphyxia at birth. Respiratory distress syndrome. Note the hazy lung fields with reticular granular pattern with air bronchograms and hypoinflated lungs on the chest X-ray. The pathophysiology of pneumonia is infection of the fetal lung from fetal membranes, placenta, meconium, or amniotic fluid aspiration, or neonatal lung from other infants' equipment and personnel causes. Tachypnea, nasal flaring, grunting and retractions, cyanosis and hypoxemia, metabolic acidosis and shock-like symptoms such as apnea with severe hypotension, hypoxemia, and pulmonary hypertension, usually in the first 24 hours. We manage this by providing oxygen and ventilation as needed. High-frequency ventilation may be necessary. Administering a broad spectrum of antibiotics, monitoring vital signs, electrolytes, glucose, and fluids, monitoring temperature, maintaining a neutral thermal environment, reviewing the history for labor lasting longer than 24 hours, prolonged rupture of membranes greater than 24 hours, maternal fever, foul-smelling amniotic fluid, or fetal tachycardia. Pneumonia may be indistinguishable from signs of sepsis or from other forms of respiratory distress. Note the unilateral or bilateral alveolar infiltrates and effusions on the chest X-ray. The pathophysiology of meconium aspiration. Intrauterine stress or asphyxia stimulates the peristalsis and decreases anal sphinctal tone. Releases meconium into the amniotic fluid subsequently. If inhaled before or after birth, this causes airway obstruction, surfactant dysfunction, and pneumonitis, which causes cyanosis, tachypnea, grunting, flaring, and retractions. Atelectasis from the stripping of surfactant from the alveolar surface. The free fatty acid component of meconium has a higher minimal surface tension than surfactant. Respiratory and metabolic acidosis and low partial pressure of oxygen, arterial oxygen, PaO2, despite high inspired oxygen concentrations. Predisposition to air leaks from air trapping and overdistension of the alveoli. Diffuse pneumonia within a few hours after aspiration from meconium irritating the airway and lung tissue. Predisposition to persistent pulmonary hypertension of the newborn, PPHN. Also, chronic stress in utero thickens the pulmonary vessels. We manage meconium aspiration by suctioning at delivery per American Academy of Pediatrics Neonatal Resuscitation Protocol Guidelines, administering antibiotics to treat pneumonia, monitoring and correcting acidosis, providing oxygen, ventilation, surfactant, and sedation as needed, providing measures such as minimal stimulation to prevent PPHN, providing nitric oxide as needed for extracorporeal membrane oxygenation as a last resort. Note the hyperexpansion in areas of atelectasis on the chest X-ray. Pathophysiology of air leaks. Alveoli become overdistended and rupture due to obstruction, such as meconium aspiration, poor lung compliance, such as from hyaline membrane disease or congenital diaphragmatic hernia, or from excessive airway pressure, such as from manual or assisted ventilation, or uneven air distribution at birth, which could be spontaneous. Gas from alveoli rupture travels to one or more areas, including between the thoracic cavity and pleura, leading to the pneumothorax. Infant may be asymptomatic if the air leak is small, and mortality rate is high with bilateral pneumothoraces. The lining of the mediastinum causing a pneumomediastinum. Pneumomediastinum is associated with meconium aspiration syndrome. Chest X-ray may show sail sign, indicating the thymus is elevated by air. Interstitium of the lung causing pulmonary interstitial emphysema, also known as PIE, may progress to pneumomediastinum or pneumothorax. Between the pericardial sac and heart causing a pneumopericardium. Pneumopericardium is life-threatening and requires immediate attention. The infant's heart has a halo appearance on chest X-ray. Mortality rate is high with pneumopericardium. Pathophysiology of air leaks continued. The alveoli overdistension and rupture causes sudden deterioration, hypotension and desaturation, bradycardia, muffled heart sounds, and shift in heart rate point of maximum intensity, which is the PMI, decreased breath sounds on affected side. We manage this by administering 100% oxygen for term infants, transilluminating the chest to detect pneumothorax. A glow appears when light is placed next to the skin. Assisting with thoracentesis, needle aspiration or pericardial aspiration for pneumopericardium by providing pain management and monitoring the infant's tolerance of the procedure. Monitoring chest tube for bubbling, assist with chest x-ray to monitor progress. Monitoring the infant if asymptomatic, providing ventilator care if the infant requires high-frequency ventilation for pulmonary interstitial emphysema. Pneumothorax is air between the parietal and visceral pleura and can be unilateral or bilateral. Pneumomediastinum is air in the anterior mediastinum. Pneumopericardium is air between the heart and pericardial sac. Pulmonary interstitial emphysema, PIE, is microcystic areas in one or both lungs and is limited to infants with poor lung compliance. PIE may progress to pneumothorax and pneumomediastinum. The pathophysiology of persistent pulmonary hypertension is that the pulmonary vascular resistance, which is the PVR, remains high after birth and causes tachypnea, retractions, and cyanosis, low partial pressure of arterial oxygen despite high inspired oxygen, and a difference in 20 millimeters of mercury or more PaO2 between the pre- and postductal arterial blood gas results. Pre- and postductal oxygen saturation difference of 5% may indicate shunting. We manage this or prevent the high PVR by administering oxygen, which is the most potent vasodilator, providing ventilator care. The infant may need high-frequency ventilation. Ventilator strategies include hyperoxygenation to keep PaO2 above 90 millimeters of mercury. Risk of retinopathy of prematurity is minimal because most infants are born at near term. Hyperventilation to keep PaCO2 in the low to normal range, which causes alkalosis and vasodilation of pulmonary vessels. And advocating for minimal stimulation and minimizing actions that cause a decrease in PaO2, such as stimulation, crying, blood sampling, vital signs, and increasing pulmonary vascular resistance and hypoxemia. We also manage or prevent high PVR by administering sedation and analgesics for procedures and treatments, administering muscle relaxants when the infant's breathing interferes with assisted ventilation. Paralysis prevents resisting the ventilator and reduces pulmonary vascular resistance and risk of air leaks. We can also manage by assisting with surfactant replacement if lung disease is the etiology, as well as monitoring inhaled nitric oxide, a selective pulmonary vasodilator that combines with hemoglobin to become inactivated and form methemoglobin as a byproduct, which needs to be monitored during therapy. The starting dose is usually between 10 to 20 parts per million. Then the infant is immediately weaned to the lowest possible effective dose. Doses over 20 parts per million have not been shown to be therapeutic and increase risk of toxicity. We also manage PVR or high PVR by measuring blood gas in arterial lines. Persistently high PVR forces blood to shunt through the ductus arteriosus and foramen ovale, which causes murmur, hypoxia, and acidosis. We manage this by monitoring and correcting hypoxemia and acidosis to stop the cycle and promote pulmonary vascular dilation, providing blood pressure support to keep systemic blood pressure higher than pulmonary blood pressure, assisting when monitoring INO-max, assisting with extracorporeal membrane oxygenation as a last resort. Asphyxia causes kidney and liver damage, which causes decreased urine output, coagulopathies, hypoglycemia, and hypocalcemia. We manage this by monitoring urine output and blood pressure, monitoring electrolytes and bleeding, and correcting them as needed. The PPHN mortality rate and the need for ECMO varies between 20 to 40%, and the infant may have residual chronic lung disease. The etiology of persistently elevated pulmonary vascular resistance is multifactorial. The most common cause is maladaptation from fetal to neonatal life or from underdevelopment of the pulmonary lung capillaries and tissues. Conditions that contribute to the development of PPHN include the following: meconium aspiration, central nervous system depression, or delayed resuscitation, which cause intrauterine or neonatal hypoxia, asphyxia, which can induce persistent vasospasm and cause hypoxia and vasoconstriction, hypothermia, and hypoglycemia, which contribute to acidosis and lead to pulmonary vasoconstriction, respiratory distress syndrome, meconium aspiration, pneumonia, and sepsis. These can cause pulmonary vasospasm, which in turn causes hypoxia, leading to acidosis and pulmonary vasoconstriction. Medications during pregnancy, such as aspirin, prostaglandin inhibitors, lithium, phenytoin, can cause a premature closure of ductus arteriosus. This forces cardiac output into the lungs, causing abnormal development, and leads to pulmonary hypertension. Lesions or lung masses such as pulmonary hypoplasia, diaphragmatic hernia, cystic adenomatoid malformation, or congenital heart disease. These decrease blood flow to the lungs, leading to underdevelopment of pulmonary vessels and persistent fetal shunting. Factors that increase or decrease pulmonary vascular resistance. Factors that increase and factors that decrease pulmonary vascular resistance. The cycle of persistent pulmonary hypertension. In the first 24 hours, PVR normally declines by 80% from what it had been in utero. When PVR remains high after birth, adaptation to extrauterine life is impaired. Neonatal pulmonary vessels constrict with hypoxia and acidosis, which causes pulmonary vasoconstriction and persistent fetal shunting. Once vasoconstriction is present, it can persist even if the cause is removed. Breaking the cycle of persistent pulmonary hypertension, the goal of managing an infant with persistent pulmonary hypertension is to cause pulmonary vasodilation by breaking the cycle of hypoxia and acidosis. Methods to increase pulmonary vasodilation include administering oxygen to manage hypoxia, providing ventilation to help oxygenate and decrease acidosis, which causes hypertension, monitoring nitric oxide to help dilate the pulmonary vessels, and providing minimal stimulation and blood pressure support to help reduce shunting. In persistent pulmonary hypertension, the lungs may appear hyperlucent, normal, or have evidence of underlying cause, such as aspiration or pneumonia. The pathophysiology of congenital diaphragmatic hernia. Herniation of abdominal contents into the thoracic cavity through a defect in the diaphragm causes cyanosis and respiratory distress shortly after birth, barrel, chest, and scaphoid abdomen, hypotension, poor perfusion, decreased breath sounds on the affected side and bowel sounds in the chest, respiratory acidosis, hypoxemia, and hypercapnia. predisposition to pulmonary hypertension, and air leaks from hypoplastic lung development. We manage this by diagnosing congenital diaphragmatic hernia prenatally, assisting with intubation and avoiding bag and mask ventilation, monitoring for pulmonary hypertension and air leaks, providing gastric deep compression with sump tube, providing blood pressure support, providing preoperative and postoperative nursing care. Most, about 85 to 90% of diaphragmatic hernias occur on the left. Note the bowel in the chest area. Bronchopulmonary dysplasia. The definition of bronchopulmonary dysplasia, also known as BPD, has changed over time. The most widely used definition is a 36-week post-conceptual age infant with oxygen requirement, abnormal chest X-ray, and abnormal physical respiratory examination. Infants with BPD tend to be very low birth weight and have a severe course from the beginning. Clinical findings vary. The infant may also initially have minimal or no lung disease, but developing increasing oxygen needs and ventilator needs during the first week of life, as well as the first few weeks of life. The cause, prevention, and treatment of BPD are not fully understood, but appear to be multifactorial. The 4 major risk factors for developing BPD are premature birth, which is the single most important risk factor, respiratory failure due to marked immaturity, respiratory distress, meconium aspiration, pneumonia, and congestive heart failure, oxygen supplementation, and mechanical ventilation. Other risk factors include a family history of allergies and asthma, lung hypoplasia, maternal smoking, the infant's gender, and intrauterine or neonatal infection. The pathophysiology of BPD is that it is a multifactorial condition with airway injury, fibrosis, and an inflammatory response leading to structural changes, which cause inability to decrease ventilator settings, hypoxia and respiratory acidosis, audible rales, rhonchi, wheezing, and retractions, increased secretions and bronchospasm, and increased metabolism with poor weight gain. We manage BPD by monitoring tolerance of ventilator weaning using permissive hypercapnia, providing supplemental oxygen after extubation, providing bronchodilators as needed, providing RSV prophylaxis with RSV, IGIV, or palivizumab for high-risk infants, assisting with family support if a tracheostomy is needed to wean the infant from a ventilator. A tracheostomy is usually considered after 6 to 8 weeks to reduce the risk of airway complications. Providing a low stimulus environment, and providing increased calories with higher calorie formula so that volume for the infant to take is smaller if the infant is on fluid restriction. Pulmonary hypertension develops with structural changes, which cause pulmonary edema and CHF in the most severe cases, complications including BPD spells, which are severe bronchospasms with desaturations, inability to wean from oxygen, recurrent infections, developmental delays, sudden death, and gastroesophageal reflux, which is a progressive disease. We manage BPD by preventing fluid overload by monitoring intake and output to help reduce pulmonary edema and right side cardiac failure, administering diuretics to control fluid retention, which leads to pulmonary edema, monitoring serum electrolytes to monitor for hyponatremia, hypokalemia, and metabolic alkalosis, monitoring for osteopenia at 6 weeks and follow-up every 2 weeks, providing interventions to close with a PDA, assisting with a cardiac evaluation to evaluate for cor pulmonale, which is right ventricular hypertrophy from prolonged pulmonary hypertension. teaching parents about BPD, helping them recognize symptoms, and familiarizing them with the plan of care and treatments that will continue after discharge, including finding services or a case manager through their insurance plan or Medicaid, reviewing home oxygen safety guidelines when using, traveling with, and weaning from oxygen, and reviewing follow-up care procedures, planning for emergencies by developing a plan and confirming access to 911, teaching parents how to use the monitor and perform CPR if possible, if the infant is going home on a monitor, teaching techniques for feeding the infant, if the infant has oral and feeding aversions, regurgitation, gastroesophageal reflux, constipation, hernias, or strictures, demonstrating use of the gastrostomy tube if applicable, return demonstrating drawing up medications, having parents fill prescription before discharge if possible, bringing them to the hospital for teaching, and teaching parents about RSV prophylaxis for high-risk infants. Note the lung hyperinflation and cardiomegaly. In pulmonary hemorrhage, the pathophysiology, there are localized areas of bleeding into the alveoli or massive generalized bleeding causes. There is sudden severe respiratory distress and red blood suction from the trachea. We manage this by providing ventilator care as needed, administering packed red blood cell transfusion as needed, and identifying and treating an underlying clotting disorder. A pulmonary hemorrhage usually occurs as a complication of an underlying disease such as asphyxia, patent ductus arteriosus, heart disease, or sepsis. If bleeding is massive, the outcome is poor. If the hemorrhage is small and isolated, the infant will recover, and the outcome depends on underlying disease. Apnea of prematurity. Definitions of apnea. Central apnea is no respiratory effort, no chest movement, and is seen with neurological immaturity. Obstructive apnea is an upper airway collapse or obstruction with continued breathing against flow and is seen with hypoxia or central apnea, airway collapse, and secretions. Mixed apnea is a prolonged pause with chest movement but no airflow. Respiratory effort against obstruction may prolong apnea. Mixed apnea exhibits components of both central and obstructive apnea. Periodic breathing is common in preterm infants and may occur in term infants for a limited duration. Periodic breathing is a sequence of 3 or more successive respiratory pauses that lasts more than 3 seconds with less than 20 seconds of normal respiration between pauses and is a frequent cause of prolonged oxygen desaturation. Immaturity of the central nervous system causes a 20-second cessation of breathing and any length of breathing interruption if accompanied by sudden cyanosis, pallor, hypotonia, and bradycardia. We manage this by providing cutaneous stimulation and documenting episodes, suctioning the airway as needed, and ruling out other causes of apnea such as head and body position, hypoxemia, anemia, infection, medication, reflux, and intraventricular hemorrhage. We also manage by administering xanthine therapies such as theophylline or caffeine. Apnea of prematurity is also managed by providing continuous positive airway pressure and assisting with pneumogram to differentiate central, obstructive, or mixed apnea. In chest tube care, we need to observe for an air leak, bubbling, in the air leak monitor. Continuous bubbling indicates a persistent air leak. Intermittent bubbling indicates an intermittent air leak. No bubbling indicates that the air leak is resolved. Apply suction in the ordered amount. Monitor changes in the patient pressure chamber. Fluctuation in the chamber indicates how the patient is progressing. When the tube is connected to suction, the infant's pressure will equal the suction control setting plus float ball level, which serves as a manometer for measuring intrathoracic pressure. Be alert for sudden deterioration. Check the airway, respiratory effort, and breath sounds. Ensure that the chest tube is securely placed. Monitor bubbling. Provide oxygen and call for help. Anticipate chest x-ray. Assess the redness and swelling around the chest tube site and monitor the chest tube site. In tracheostomy care, we monitor for rattling mucus sounds, increased breathing, or change in breathing, bubbles of mucus, cyanosis, restlessness, change in blood pressure, and desaturation. Prevent or manage these issues in the NICU every 4 to 6 hours or as needed, depending on the condition. An infant with a new tracheostomy may have large amount of secretions, which will decrease over time. Suctioning is usually done with a sterile technique with a sterile catheter and glove. At home, parents can manage with suctioning as needed using modified clean technique, sterile catheter and clean gloves, or a clean technique, clean catheter and clean hands, usually at home. It is always helpful, though not always possible, to have a portable suction ready for teaching. Have the parents identify the signs of respiratory distress, return, demonstrate, and assist them in becoming comfortable suctioning before the infant's discharge from the NICU. Monitor for redness, pressure areas, and signs of necrosis at the site. In the NICU or at home, prevent or manage these by changing dressings daily and changing the tube weekly or as needed. Monitor for desaturation. In the NICU, prevent or manage desaturation by having extra tracheostomy tube and endotracheal tube at the bedside, following your unit guidelines. Have oxygen available. At home, the parents can manage by knowing CPR and having oxygen and an extra tracheostomy tube available. Medications. Aminophylline or theophylline. Aminophylline is generally given intravenously, and theophylline is generally given by mouth. Aminophylline is approximately 80% theophylline. Use conversion when converting from IV to PO. Adverse effects include cardiac arrhythmias and seizures with toxicity. Monitor serum levels for signs of toxicity such as tachycardia, jitteriness, irritability, and feeding tolerance or intolerance. If the heart rate is 20 beats per minute above the baseline or above 180 beats per minute, hold the dose, notify the physician or practitioner, and anticipate checking the level. Consider changing to intravenous dosing if the infant is on an oral dose with suspected necrotizing enterocolitis to reduce gastrointestinal irritation. In caffeine, it's usually well tolerated with levels less than 50 micrograms per milliliter. Above that level, jitteriness, tachycardia, and mild glycosuria have been noted. There is less diuretic effect with caffeine than with theophylline. Nitric oxide. Inhaled nitric oxide should not be used in neonates with ductal-dependent lesions. It is not possible to administer 100% oxygen when providing nitric oxide because the nitric oxide dilutes the oxygen in the circuit. Do not interrupt the supply of nitric oxide. Backup power should be used in the case of emergency. Nitric oxide is used in combination with other measures, high-frequency ventilation, oxygen, vasodilators, to decrease pulmonary hypertension. Baractant, monitor heart rate, color, chest expansion, breath sounds, oxygen saturation, and endotracheal tube patency before and after each dose. Anticipate ventilator changes. Applications. A 12-hour-old infant is delivered at 37 weeks gestation with thick meconium and is on mechanical ventilation. The infant suddenly deteriorates with bradycardia, pallor, desaturation, and muffled heart sounds. What condition do you suspect? You suspect an air leak. Lung overinflation and air trapping predispose the infant to alveolar overdistension, causing an air leak. A chest tube is placed in the infant, and the infant develops a rising oxygen need. By 24 hours of life, the infant requires 100% oxygen with a saturation of 85%. PPHN is suspected. What factors put this infant at risk for PPHN? Meconium aspiration can lead to hypoxia, which causes vasospasm. Pulmonary vasospasm increases hypoxia, leading to acidosis and pulmonary vasoconstriction. A vicious cycle of hypoxia and pulmonary vasoconstriction, acidosis, and persistent fetal shunting can occur. Which medication do you anticipate will be used for pulmonary vasodilation? Inhaled nitric oxide is a selective pulmonary vasodilator. It combines with hemoglobin to become inactivated and forms methemoglobin as a byproduct, which needs to be monitored during therapy. Starting dose is between 10 to 20 parts per million. A 30-week-old infant with severe lung disease who has been intubated for an extended period is having BPD spells. What does this refer to? BPD, bronchopulmonary dysplasia, is a multifactorial condition with airway injury, fibrosis, and an inflammatory response causing structural changes. BPD spells are severe bronchospasms with desaturation. The infant is gaining weight very slowly. What are some ways to increase the growth? Increase caloric content and decrease oxygen demand. At a post-conceptual age of 41 weeks, the infant has BPD and is ready for discharge with home oxygen. Based on history, what factors did this infant have for developing BPD? The infant has had all the major risk factors. There are 4 major risk factors for developing BPD. Preterm birth, which is the single most important risk factor, respiratory failure, marked immaturity, RDS, meconium aspiration syndrome, pneumonia, and CHF, oxygen supplementation, and mechanical ventilation. Complications of BPD include pulmonary edema, CHF, cor pulmonale, BPD spells, and inability to be weaned from the oxygen, recurrent infections, developmental delays, sudden death, and gastroesophageal reflux. What are some important preventive measures for families of infants with bronchopulmonary dysplasia? Not smoking, respiratory syncytial virus prophylaxis, avoiding crowded areas during RSV season, CPR training, and training how to use oxygen.